going to go ahead and start recording this last section, and here we go. All right, so peripheral vascular disease. We have venous and we have arterial peripheral vascular disease. First is the venous. So these are the venous problems that we look at. Venous thromboembolism, you also may note it as a DVT, and varicose veins, which is usually not treated in an inpatient. Also, you may notice leg ulcers because the veins get distended, congested, and develop wounds. And they have chronic problems of their veins not functioning well, and they develop a problem with recurrent clots in their legs. Picture of why it happens. In our veins, we have these one-way valves, and over time, those valves may not function well, may not close off and let it. Yeah. Sorry, Dustin. I'm drowning, and I'm dying and giving it to you. Okay. All right. So those valves don't work well. They start letting the blood slip back down towards the feet. It pools there, and you'll notice they have like swollen, they call it engorged, swollen legs. Okay, that's the mechanism. All right, so for varicose veins, it's what we all need to do. As nurses, you're at risk for this because you stand on your feet all the time. Okay, so avoid standing too long periods of time. Standing or sitting because the circulation is impaired either way. And anything, if it's too tight and can leave marks on you, can cause venous stasis. Crossing your legs, obviously, is not a good idea. So what they need to do, put their legs up every day. Like on a recliner, footstool, something, a couple pillows, lay on the couch, a couple pillows, get your feet up so that promotes that blood, that edema, getting it back into the vascular system and back out of your body. Every hour, walk a couple, do some walking or pumping your legs, like especially nurses standing there in front of their wells, pump your legs. Wear compression stockings. Anything sport goes all the way to the actual prescription brand of compression stockings. And lose weight because that puts more pressure on the vascular system. Severe cases, they may do some surgery procedures. They may require some anticoagulants. If they're hospitalized, get them up and get them moving is the best thing for them. All right. So peripheral vascular disease. This should have had a label on here for DVT. Okay. All right. For deep vein thrombosis, write that there if you have that printed up. This is for deep vein thrombosis. So that's slide 07. The deep vein thrombosis is not there. Okay. So for superficial veins, these people don't get hospitalized. If they develop a blood clot in the superficial veins of their legs, they're going to be put on bed rest, elevation, something for pain, NSAIDs for inflammation until the situation resolves itself. What happens is they'll get maybe a blood clot in a superficial vein. It'll cause pain, tenderness, redness, and warmth. Very little chance of that dislodging and going anywhere to the heart or anything like that. But the deep veins, that's a different story. But for superficial veins, treatment at home is usually indicated. What does it look like? One side, the affected side is warmer, it's swollen, the veins may be prominent, it's tender, and this really is getting more, this one is really getting more into it. My labels are missing here. Why? My label's missing. This one is what we would look like if you've actually developed the deep vein thrombosis, okay? The superficial vein thrombosis is the previous slide. This one's the deep vein thrombosis. So it is, slide number 8 is deep vein thrombosis that they'll have the prominent superficial veins because what's happening is they do. Okay, they are there. I cannot see them at all, huh? So I'm relieved to know that. Great. Okay. What happened to my slide? Okay. Um, so they are prominent superficial vessels trying to take the blood flow that is being affected by the deep vein being having an occlusion or partial occlusion, so that it's like the freeway gets somebody has a traffic accident, they're T-boned, that they're blocking that one lane. So then we're trying to find other ways around it, and so that's why you'll notice your side streets, are all congested. Same thing with your superficial veins. It's tender, um, and especially though they may just describe it as a heaviness or aching, but often it's a tenderness in the it's really tender, maybe even some kind of sensitive pins and needles. You touch that leg, that location is warmer than the other leg, and it's typically swollen, and it's including may swell all the way down to the ankles. Um, you hear somebody mention a Holman sign, just know that that's no longer evidence-based practice. That's something we were taught in the past. And if you hear them talk about the Holman sign or you see a question about it, just ignore it, pass on when you're doing like a test bank, because that is no longer evidence-based practice. Okay. Now then, so what causes them? Well, it's this triad. Virchow, the guy who named this, but basically three things happen. The lining of the blood vessel of the vein is being damaged. What damages a blood vessel? Well, putting an IV in somebody can damage a blood vessel. Just FYI, you can create the risk for that by somebody having a prolonged, even a peripheral access can do that, but more so when they start getting into these, either the PICC lines, okay, that often we'll see it. So trauma, somebody who's in multiple vehicle accident, somebody who's had surgery, you have damage done to the blood vessels. So anybody post-op is at risk. Venous stasis, that means the blood's pooling, it's not really being moved out of the legs and into the trunk. Well, who has stasis? Well, somebody who's immobile, especially somebody's had orthopedic surgery. So that's a two for surgery and orthopedic, and they can't move, their mobility is limited. Obesity, again, causes venous stasis because of the physical pressure of the adipose tissue. If they have varicosities, that's another, the blood's going to pool. Spinal cord injury, because that affects how our circulation goes as well. It tends to create a vasodilation, and so that their blood vessels are kind of dilated and they're laying there. They can't move their vessels, they can't move their legs. They're more at risk for that. So anybody immobile, anybody over the age 65, they have more risk of venous stasis, which is one of the factors creating a blood clot. And then altered coagulation. People with cancer. Pregnancy is a hypercoagulable state, so pregnancy is another reason why people can have a blood clot. It is possible to develop blood clots in pregnancy. Taking birth control pills, because again, they mimic some of the hormones of pregnancy, that they also can cause increased risk of blood clots. Somebody who inherits a clotting disorder, and anybody who has septicemia, like you get an infection in the bloodstream, it affects your coagulation. So what do we do about it? Well, here, very different between preventative and treating a blood clot. If you're at risk for deep vein thrombosis, early mobilization of leg exercises, compression stockings, or those SCDs, those things that you put on them while they're in bed. Have y'all seen SCDs? I forget, you have not been in the hospital. Sequential motion devices, okay, some of you have, okay. So SCDs, these are all what we do for preventative care. Once they have a blood clot, I don't want to massage that leg. I don't want to be squeezing that leg with these stockings and pulling them up the leg. I don't want to do anything that could break loose a blood clot by massaging them with the SCDs. But for preventative, they've had surgery, they had orthopedic surgery, they're 68 years old. At post-op, these things should be happening to them. Okay, get them up, get them going as soon as possible. Get the compression stockings on them if they need them, or have the SCDs on. Now, we will put these medications on both groups of people, both to treat or to prevent. They'll go ahead and anticoagulate them. and this is a list of some of the drugs that we might choose. If they have a blood clot, it is bed rest. Do not move the extremity. Don't exercise it. Do not put it up above the heart. We want that blood clot to dissolve and go away and restore circulation. Okay, and so they will either anticoagulate. In severe cases, they may use a clot buster like TPA or kinase, and they can inject that and try to deal with that. I notice my camera is stopping and starting from time to time. Not sure what's doing that. I'm going to ignore this slide. This is really was really more about FYI, okay, about the long distance travelers. And I know Ms. Medic went over the coagulation issues, but remember, we want to pay attention to these blood tests. The activated partial thromboplastin time is done to measure somebody's clotting ability. And so they will measure the ATPP, which is the clotting of the plasma. And the reference values on that will vary from lab to lab, but somewhere around 25 to 38 seconds, okay? This is what we use to monitor heparin therapy. So the activated partial thromboplastin time is the test we use to monitor the heparin therapy. What we want, how do we know we're therapeutic with our heparin and not too much or too little, is that we have their APTT between 1.5 and 2.5 times time the mean, okay? Usually your result will come back, that it's 1.2 or it's 2.8 or whatever. We want it to be between 1.5 and 2.5 if they're on heparin, okay? And they will usually tell you that because otherwise you would have to go, well, what's 1.5 times 25 and do the numbers, but they will give you those values. INR, International Normalized Ratio. Now, if you're just a normal patient, they would do a thing called a PT, which is a prothrombin time. Let me check, type that. Prothrombin time. And your prothrombin time should be 11 to 13 seconds, and your INR should be 0.8 to 1.1 for a normal person, okay? So those are without any anticoagulants, what people know as blood thinners, okay? This is your normal range. But if you're taking warfarin, we want to follow your INR, and your INR will be between 2 and 3. That means we're anticoagulating you without putting you at significant risk for bleeding. So your normals are for the PT is 11 to 13.5 seconds with the INR of 0.8 to 1.1. If I've got you on warfarin, that's, maybe notice Coumadin, then it would be between 2 and 3. So for heparin, APTT. For warfarin, INR. You should know the antidotes for those medications too, by the way. All right, I am going to do this. This is real important because very often we'll give a question, ask you who's at highest risk here, and these are it's a real common sense way to approach it, but you kind of need to be walked through it. So who's at highest risk here to have a deep vein thrombosis, a venous thromboembolism, also known as VTE? The 50-year-old post-op, 25-year-old with a central catheter in place for septicemia, 71-year-old otherwise healthy individual, or the pregnant 30-year-old due in 2 weeks. Okay, so we got a little bit of a dispute going on about which one. So here's how you do this. All right, 50-year-old post-operative patient. How many risk factors did she make? Post-operative, right? That's one risk. Now, if I had said post-operative patient who is immobile from a hip fracture, that would have been 2 risks. All right, 50 years old. 25-year-old, well, the age doesn't get it. Central line catheter, central venous catheter. So that means I've got a central line that goes up here and it's into it drops right here. A long catheter that drops right here in front of my heart for IV fluid. And septicemia. So I've got the central line and I've got septicemia. I have 2. Okay. C, 71-year-olds, otherwise healthy individual. 1. Pregnant 30-year-old, 1. So the one that had the most was B because we counted the most risk. All right, that's how you do these about who's at highest risk. You see these often as a test question. All right, and it explains it here for you. Okay. All right, now then, what we're looking for. This is peripheral venous insufficiency at its worst. Okay. This is somebody who has venous insufficiency. They get venous stasis. They develop these blood pools. The legs get congested, and we start seeing changes in the appearance of the legs. You notice how these look like they've got like little kind of discolored or rusty colored sleeves on the legs? That's a thing called hemosiderin, and that means that the blood is set there so long that it tends to break down and leaves deposits of iron in the tissue, and that's why you see the color. Just like the Franklin Mountains, you know, have that reddish color because of the iron. But also because our circulation is impaired, we start seeing these nasty stasis ulcers. And you can see here where this person's had multiple ones that have healed, and then here's a new one. Okay. Give that picture in mind. That is venous insufficiency, peripheral venous insufficiency. Okay. And this is describing what you just saw. It can be painful. Often the skin's dry and cracked. They get dermatitis, how her skin was just, then that kind of describes it, dry and flaky. What's going on? They can get blood clots. Somebody who has hypertension, remember your hypertension just isn't in your head or your heart, it's all throughout your body. So hypertension in the legs is causing damage to the blood vessels in the legs. Smoking damages blood vessels, especially peripheral blood vessels, especially the ones in the leg. Obviously, sedentary lifestyle and diabetics always on the list of things that damages blood vessels. Okay. All right. So this is the history you would get and the things you assess for. The risk, complications, or infection and gangrene. Typically, though, it's this problem of these wounds that won't heal, and these wounds get infected. They have to take massive, nasty antibiotics, and that can have its own complications, like C. diff. So it's real important that we tell them how to, take care of their legs and to monitor carefully for that. All right. So this will say peripheral. Yeah, peripheral. I can see it if I sit way back. Peripheral artery disease. Okay. So I've told you about venous insufficiency. Keep that in mind. We're going to compare and contrast that to arterial insufficiency. So think about it. If my veins have problems flowing, I get this congestion, I get this edema, I get these nasty open wounds because the circulation's impaired in terms of everything's pulling there and it's sluggish. And so I'm good to get these nasty looking sores and I get all that discoloration. Okay. So what happens when my arteries are not working? And this especially is a risk of people who smoke, is peripheral artery disease. So we develop plaque and clots in our arteries, in our legs, just like we do in our heart or our head. So we have to deal with the same problem. This just reminds you where your pulses are in the lower legs, if you need a review for that. Okay. Okay. Did I miss a slide? No. Okay. I think this is getting as tired as I am. All right. So using a Doppler, we can do a blood pressure test that's non-invasive to see if somebody has peripheral artery disease. You can put a blood pressure cuff on their arm and check their blood pressure. You can put a blood pressure cuff above their ankle and do the systolic pressure either on the posterior tibial or the dorsalis pedis. So I take my blood pressure, my systolic blood pressure from my ankle, divided by my systolic blood pressure from my brachial artery, and I should get a number of 1 or greater, okay? Usually about 1 to 2, okay? So there shouldn't be too much difference between them. In peripheral artery disease, when I divide that ankle blood pressure by my brachial blood pressure, I'm going to get a number less than 1. And that's indication that they're developing peripheral artery disease. Claudication is simply a term that means when I walk, it hurts. When I stop, the pain goes away. And at first, that's what happens. They say, I've been trying to walk to help with my blood pressure. And when I walk, my legs they hurt and ache, and very, very achy pain. And when I stop, the pain goes away. That's called claudication. That means that is the early signs of our peripheral artery insufficiency. All right, that the arteries are not perfusing. Okay, they're not able to push the blood through the artery into the bottom of the foot so that it can come back up. All right, and eventually, though, they get that rest in their legs all the time. All the time. This test is known as an ABI, an ankle brachial index. So they check your ankle brachial index. That's that blood pressure I just explained to you. All right. Diabetes. The test is accurate with people who have diabetes. Just an FYI. All right. So we've looked at arteriosclerosis and atherosclerosis as cause for the peripheral artery types of diseases. This was all the ones that are in your chapter. The only thing we're looking at is you should know atherosclerosis, you should know peripheral artery occlusive disease, and you should know Raynaud's. So you're going to skip all of the rest of this in your book. Don't bother to read all of that chapter. You just need those 3 sections, okay? So what's happening? This is what it looks like. The circulation, remember my artery is occluded or partially occluded, so the blood coming down is not getting all the way down to my feet and back up. So I'm not going to have good artery circulation coming down. The temperature of my leg is going to probably be coolish. I'm going to have weak or absent pulses. They're going to have that claudication or even pain when they rest in their legs. The skin changes, the skin breaks down because it's not got the arterial perfusion. And notice the sores here. Usually they're like in a ring, they're annular, and see how that doesn't look so wet and weepy, how dry this looks. So they get these lesions that don't look that bad, but it means that I have impaired arterial circulation to that foot. That foot can be at risk for having to be amputated at some point if I cannot get the arterial blood flow to the leg. Because I have impaired circulation, they grow these thick, nasty type of nails. Okay, I don't exactly know the mechanism why, other than they don't have good arterial blood flow. All right. Not all of them look that dusky, but the legs are hanging down. They don't get blood flow down. So if they've got arterial occlusion, if I were to tourniquet my leg and let it hang down, it would look really fun. It would turn that color too. All right. And I've explained this to you. Smoking is a big risk factor. Hypertension is a big risk factor. Okay. And also if they have dyslipidemia. All right. So we're wanting to preserve blood flow. That's the big deal here. Okay. And try to keep them, maintain their skin integrity because the skin's at risk here. So exercises of graded walking, isometric exercises, typically they would have them go and get some therapy to teach them the isometric exercises. Now, positioning of the legs. And this sounds strange, but with peripheral artery disease, I actually do want my legs hanging downhill because that will help, the gravity will help pull the blood down the artery to the bottom of my feet. When they raise their legs up at their heart height, they actually will have their legs turn pale and cold because the blood flow can't get to the feet. All right, so their legs are hanging either neutral or dependent, meaning down, downhill, as opposed to the ones that have the insufficiency, that are edema and everything. They're having trouble getting the blood back up to the heart, so we need to put the legs up for venous insufficiency. For artery disease, the legs are neutral or hang down. They're very sensitive to effects of cold and heat. Need to stop smoking, stress, because it affects our vasoconstriction, and they already have trouble with their arterial circulation, so that they don't want to have stress reduction. You'll see them on these different drugs to try to prevent problems with blood clot again because the blood's going to sit there and not be able to travel down here. They would typically be on anticoagulants or antiplatelet drugs as well. Okay. Then this drug, this PDE3 inhibitor for claudication, is also given for pain. Okay. Altered peripheral tissue perfusion, risk for impaired skin integrity, chronic pain. All right, that you're going to answer those. So now I put it in a. I'm getting to Raynaud's in a minute. Okay, this is my last few slides are Raynaud's. All right, arterial. So this is comparing the list of signs and symptoms. Arterial, you have diminished or absent pulses. The venous, the pulses are present because it's not a problem with the arterial blood flow. It's a problem with congestion. Remember. So the dependent rubor, that's what that foot looked like. The second one you asked about the toenails on. The color of that leg was dependent rubor, okay? And the skin sometimes is quite shiny, and I don't know why that's an effect of arterial issues. But the ulcers tend to be on the tips of the toes or the heel. They're deep, circular, dry lesions, very little edema with arterial problems. Contrast that to the venous one I showed you with the weepy sore, okay? So it has pulses, has that discoloration staining on the legs. It may be bluish, but it's going to be warm. That could be cool to touch, okay? Ulcers may be over the ankle bone, the malleolus, or the tibia. And so up and down on the lower leg especially. Superficial, irregular, weepy borders with usually severe edema. So go back and look at those pictures, compare them. Last slide is Raynaud's. Raynaud's is a vasoconstrictive disease, but it's an intermittent problem. So basically you have arterial spasms, and they create discolorations and temperature changes in the hands and feet. And they can actually look like this where they're totally pale or where they're discolored on the tips. But it's a vasospasm of the arteries. What do we know about it? It's typically associated with other underlying diseases, especially autoimmune things like scleroderma. And it's a sudden vasoconstriction causes the color changes, and obviously your hands will be numb and tingling, okay? Let me get back to that. Okay. Episodes typically have a trigger. Cold, stress. Sometimes there are certain drugs some people say that triggers them, but mostly it's environmental. So they often will wear gloves or make sure that they wear socks if it typically affects their feet. So protect them from cold and the triggers. Avoid injury to their hands and fingers. Raynaud's. Okay. Now, I just thought I found that last night. I thought I like that. Now, I know that the children with COVID are having some issues with their more like their circulation in their extremities. I really have not read up on that, so I really couldn't field that question for you, Wendy. I have to look and see if Raynaud's is actually one of the conditions that they're seeing. Okay. So I'm going to end my slide.